Over the last 24 hours, we have identified 5,384 cases of COVID-19 and completed about 13,879 tests. Our positivity rate for lab-confirmed COVID is about 38%. There are currently 635 people being treated for COVID-19 in hospital, including 72 in the ICU. I want to note that starting today, our historical ICU numbers may look a little different for a few dates in the past. As we have been doing continual quality assurance work with our data, it was identified over time some units in some hospitals have shifted back and forth between being available for use as an ICU unit or a non-ICU unit. In some of our historical data, patients admitted for COVID treatment were categorized as being in ICU when the unit they were on, in fact, had been changed back to a non-ICU unit at that time. The adjustments you will see in historical data today now reflect correctly the type of care those patients were provided. This means you will see a decrease in ICU numbers at some points in time, with a corresponding increase in non-ICU numbers. The updates do not change the significant pressure that the system has experienced in each of our previous waves. This is simply an adjustment as we continue to be committed to transparency in our reporting. Sadly, 6 new deaths have been reported to us since January 6th. My deepest sympathies are with the loved ones of these Albertans and anyone else who has lost a loved one, no matter the cause. With our recent increase of Omicron cases, demand for PCR testing has pushed our testing system beyond its capacity. As many Albertans have found, just getting an appointment for a swab takes several days, and the time to get results back is now close to 48 hours after the swab is taken. While we have used widespread PCR testing to manage COVID-19 in previous waves, this approach is just not possible with the Omicron variant. In order to ensure that patient care decisions are supported by timely diagnostic information, PCR testing eligibility will now be focused on those with clinical risk factors, for severe outcomes, and those who live or work in high-risk settings. Effective immediately, PCR tests will be available for only those in specific categories. The full list can be found on our website, but some examples include continuing care residents, healthcare workers and staff in acute and continuing care settings, shelters, and correctional facilities, symptomatic household members of a person who works in continuing or acute care, individuals with any degree of symptoms who have risk factors that would make them qualify for monoclonal antibody treatment if positive for COVID-19. This list is available on the website and includes those with significant immunocompromising conditions. All residents and workers from isolated and remote First Nations, Inuit, and Métis communities, returning international travelers who become symptomatic within 14 days after their arrival so we can monitor for new variants, and hospital or emergency department patients of any age who were ill enough that COVID testing would change treatment plans. I want to specifically note that going to an emergency department does not make someone eligible for a PCR test. So please do not go to emergency unless you are sick enough to really need urgent treatment. Making decisions about in-person schooling is not straightforward, especially with the Omicron situation. We have always tried very, very hard to keep kids in school, and similar to colleagues in BC, and I've discussed this at length with colleagues in BC, where we know that there are significant impacts to kids' health if we keep them out of school for long periods of time. So there is no perfect answer, unfortunately, and right now with the return to school at the time of high transmission, there will be occasions where individual schools, individual classes will need to move online for periods of time simply for operational reasons. However, I believe that, again, when we can't, there's no perfect solution. We need to look at that balance and making sure that kids have an opportunity to go back in person where the school system can receive them, increasing the protections. So when it comes to enhancing the quality of the masks that are available to kids and teachers, providing rapid tests so that there can be asymptomatic screening done, those are additional levels that we can offer. But again, similar to colleagues in BC, we've weighed all of those things and determined that we want to offer kids the opportunity to go back, even though we know there will be some operational challenges. We'll have to focus responses on areas where, unfortunately, we are seeing that local impact. But to deprive all children across the province of that opportunity to go back, again, is a significant health risk as well. So in this environment, we're trying to do the best we can to balance all of those competing interests. I think it's clear that there are many more people with COVID than are being diagnosed, partly because of the changes to eligibility that were necessary so we can focus PCR testing on those at highest risk, but partly because many people have very mild symptoms. And as we know through previous waves, not everyone comes forward for PCR testing. So I think it would be fair to say that in previous waves, we've seen a range. I think I've mentioned catching 1 in 4 cases with PCR up to about 1 in 6 in the 4th wave. I think it would be very conservative estimate to say we're 1 in 10 or greater at this point in time in terms of the number of cases that we're catching, which again is why it's so important for everyone to assume that anywhere they go, there's going to be someone infectious with Omicron. And to be very clear, that's not to say that we should stop trying to slow the spread. I believe that's very important to slow the spread to protect the healthcare system. And it does take actions on all of our parts to do that. So again, I couldn't give a specific number, but it's very clear with a 40% positivity rate that transmission is higher than it's ever been before. And we should assume that at minimum, we're seeing about 10 times or more the number of cases that we're diagnosing through PCR.